Conway Hall, London, where ethics matter.
Welcome to Conway Hall, where ethics matter. I think we're the longest established ethical society in the UK, pretty sure about that, and we pride ourselves on being a hub for free speech and independent thought. Today we're asking, what does it mean to be well? Is this something in our body, or rather is it something subjective, something of the mind? And that is why we have an eminent psychiatrist, Alastair Santhouse, who is a consultant psychiatrist at both Guy's and the Maudsley Hospital. His clinical work focuses on the intersection of physical and mental health. So welcome, Alastair, very much, and we'll be having questions later. Thank you very much.
Well, thank you for the introduction and for the welcome, and thank you all for coming today. Really very much appreciated. The word eminent in the introduction always sends a frisson of anxiety somewhere inside me, but I can hardly wait to hear myself speak now, so thank you very much. So, how did we get here was the first question I put to myself, and when I constructed this talk, I found myself writing rules about why we are in the position we've got, and I got to the 12 rules, and then I realized it sounded like another book, so it's nothing to do with the other 12 rules book. This is mine. And first of all, a little bit about me, just to give you some sort of notion of why I'm talking to you today. So I trained in Cambridge in the late 1980s, because I'm older than I look, of course. And when I trained, I'm not sure I knew there was a job like a psychiatrist. I remember thinking, at my interview, I was asked what book I was reading, and I wouldn't have remembered to tell you now what book I was reading 30-something years ago, only because of those flashbulb memories. I was reading a book called The Inner Game of Tennis, which is absolutely typical of the kind of book that I would have been reading at that time. And it just so happened that the interviewer, the director of studies, was a very keen tennis player, and I think his well, anyway, I told him about how to improve his inner game of tennis, and he was hanging on my words. It was just the best interview I've ever done, before or since. So, and my training was very sort of technical. It was rather dry and academic, and I didn't really mind that. But once I got into hospital medicine, once I'd qualified, I went down the track of being a hospital physician. And for a few years I worked on the wards, and I was in the medical, well, these brutal on-calls, and I began to see that things were not always what they seemed. What I'd learned in my textbooks about health and illness were not what I was seeing once I'd actually got onto the wards. I remember as a medical student seeing someone, and I just didn't buy his story at all. And everyone else seemed to take it at face value. Look, he's complaining of abdominal pain, and I was asking him all about this pain and where he, could we verify the records from anywhere? And it was all a bit vague. And it was all, he worked, I think, on a cruise ship or something like that, so he couldn't access any records. And then he remembered something from a hospital near a station, and then I went to look up, and every single London hospital is not more than about a minute from a station. And I remember thinking, I don't buy this story. And I remember they took him to theatre, and they discovered he'd been operated on lots of times before and never found anything wrong. And it became clear that he'd simulated his own symptoms for the purpose of having an operation, which is not as uncommon as you might think. I began to see people who really their symptoms were a reflection of something else going on in their lives. And this notion that we had of what medicine was began to loosen in my mind. I became a member of the Royal College of Physicians, which is a fearsome set of exams, and even now I still sometimes have dreams in which I'm about to take them tomorrow and I wake up in this terrible sweat. I went from there so once I got that membership of the Royal College of Physicians, I went back and decided to do what I think I should have done all along, which was become a psychiatrist. So I retrained as a psychiatrist, and my professional career has been working in the interface between physical and mental health. And I do now neuropsychiatry and general hospital psychiatry. And over the course of the next sort of 40 minutes or so, because the first thing ever I do when I see a talk is to look how many slides there are, and sometimes groan slightly if there's too many, but I'm pretty good at keeping to time. And I should finish at when? Somewhere between 3:45 and 4-ish, right? Okay, now the audio-visual stuff has been unveiling lots of surprises for us today, and it's revealed its latest one just now, which is this clicker. It doesn't work at all. So I'm going to have to do the next slide, please, which sort of takes me back to the pandemic, but there you go. So next slide, please. So the first rule that I have is that we all want life to make sense. And I think it's a very powerful urge that we have, that things should make sense. And in my experience, it's very rarely challenged. I think very often life doesn't make sense in the world of quantum physics. Things just don't seem to make sense as we understand them. And I've come to believe that in medicine, things shouldn't always make sense. We'll just go on to the next. Yes. So here's a quote from Daniel Boorstin, who's an American historian. There's lots of different quotes in my book, and it would it's always difficult to know exactly what someone said and when they said it, or maybe they said similar things at different times and everything. But what Daniel Boorstin said was something that stuck in my mind a lot. The greatest obstacle to discovering the shape of the earth, the continents and the oceans was not ignorance, but the illusion of knowledge. And I think this illusion is quite a tempting one. To think you know it all already means that you stop asking yourselves the difficult questions, or even any questions, about where you need to go from here. So we'll go on to the next slide. I think we have a need for order and logic and clarity in everything that we do. And I think that our drive for things to make sense has been there right since ancient times. And we'll go on to the next slide. All of these are a surprise to me now, what's about to say. So the four humours theory was an attempt, first of all, to make the world of medicine make sense. So health and illness had been seen rather as a spiritual matter in the early days in the ancient times. If you were ill, you would go to your priest rather than to a doctor. And Hippocrates and then Galen, or I think it was vice versa, I forget now, but they talked about the four humours, which was a way of bringing the physical into medicine and to leave out the spiritual. So if we just keep going. So there was the four humours theory, which I think most of you have heard of, right? And the four humours theory said that you had these four elements in your body: blood, phlegm, bile, and black bile. And in case you've forgotten what a blood cell looked like, there one is. And what he described was that these four humours needed to be in balance. And it was the physician's job to balance them. So blood was sort of hot and wet, and phlegm was cold and wet, bile hot and dry, and black bile cold and dry. And anything could affect your humours. So it could be something to do with the weather, the temperament, whatever it was, your humours could fall out of line, and it was the physician's job to identify what that was and to correct them. And this is a very compelling theory, because the four humours corresponded to the four seasons, they corresponded to the four elements: air, fire, earth and water. So phlegm, for example, was the season of autumn, and of course explained why your nose dribbled a bit in the autumn season, for example. It was a very powerful, comprehensive theory. And we'll just go on to the next slide. I think I've covered that one, except for the final point about it explaining your personality. And we'll just go on to the next picture. So these are the sort of four personality types that you can see that the humours cause. So you won't be able to read them, but the the top left, out of phlegm, cholera, black bile, or blood, which do you think is the top left one? So he's the phlegmatic person. So he has a natural excess of phlegm. And the top right has a natural excess of cholera, this yellow bile, and you can see it looks sort of pretty irritable and and the person on the bottom left is sanguine. He's got a more cheerful temperament through a natural excess of blood. And the bottom right, you can probably guess, is melancholic. So black bile, so melan is black and cholia is bile. So melancholia, which is the word we've used for depression, is black bile. And so it explains your personality types as well. So we'll go on to the next slide. So the four humours was a theory that explained everything. It was neat, and it was completely wrong, of course. But that didn't stop us from using it for 2,000 years of medicine pretty well, which is amazing when you think about it. And the doctor's job when he, well, it was nearly always he, in fact, I think probably exclusively he, tried to resolve your physical problems was a way of rebalancing your humours. And they would do that by poultices or cupping, which became a bit of a craze in the Olympics in 2016. I don't know if you saw. I'm not sure what the reason was. I think the theory was that it helped blood flow. But you can see the swimmer Michael Phelps has these marks from cupping on his shoulders. Bleeding, so leeches or cutting veins, purges and vomiting. All of these were a way of trying to rebalance your humours. So there was a logic to it. We'll go on to the next slide. And it led to one of my favourite quotes from Oliver Wendell Holmes, who's a very famous American physician, who said that I firmly believe that if the whole materia medica as now used could be sunk to the bottom of the sea, it would be all the better for the mankind and all the worse for the fishes. So I think he worked out that we were just poisoning everyone, which is effectively what we were doing, by the way. I mean, we're giving them some pretty heavy toxins and some nasty substances. So the first point I want to make, and that's probably the most long-winded point of all of them I'm making, is this notion that things have to make sense, and I just disagree. Or there's maybe a sense that they make that we just can't access at the moment. So we'll go on to the next slide. I think a common sort of consequence of that is that simplistic and easy to understand medical explanations are usually preferred to more complex psychological formulations. So if you have a person with a symptom, it's tempting just to ascribe a particular simplistic explanation for it rather than to look at the whole person and try and understand why they may have developed this symptom at this time in a non-medical sort of a way. So if we go on to the next slide. I think for my money, the birth of modern medicine came when we began to understand infectious disease better. So until then, when people came down with diseases, there was sort of theories, you know, there was a miasma, there was something in the air. No one quite really understood. But gradually, over the course of the 20th century, you know, if you were practicing medicine in the 1800s, it was very much eminence-based. You know, the most senior doctor, their word was law, and that's how it happened. But empirical medicine, evidence, started to make the difference. So if we go on to the next slide. So here, the perfect example for modern medicine is infectious disease. You have a pathogen, and for those of you that did medicine or pathology, these were these sort of these were the bacteria that you would have in the agar plates. And it would cause a disease. The disease would lead to symptoms, which we know is an illness, and there was an outcome. And it may be that people keeled over and died, or it may be that this pneumonia resolved, but that was very clearly what happened. And then, if you go on to the next slide, medicine developed antibiotics in the 40s, 50s, and it addressed the pathogen and led to a cure. And since then, medicine has wanted everything to look like that model. And I think it's a really important point to make, that we want to believe that for every illness, there is a disease that we can treat. And I think that that's become, I think that's become the way we practice medicine now. And I'll go on, I'm not sure every single person always believes it, but I think the structure of medicine is set up to reinforce that model. So I'll go on to the next slide. There's a lovely quote from Rick Carlson in his book, The End of Medicine. He says, "To think of man as a machine does aid us in understanding something about bodily function and about man's role in the universe. But it does not follow that treating the body as a machine will heal it. But medicine appropriated the idea as the premise for its practice." And I think that quote perfectly encapsulates what it is that I'm trying to say, that we treat the body as a machine now. Okay, we'll go on to the next slide. And I think that it's because of that that we've got to this far more reductionist and simplistic view of physical health, that medicine has become very fragmented, very super specialized, and in your area of specialist knowledge, you're a complete expert, and out of it, you're pretty helpless. And I think that it comes from the fact that where there's a symptom, there must be a disease, and if you get more and more expert, you'll be able to treat it. So we'll move on. And this, just to highlight this, there was a patient I remember seeing, and he was in his 40s by the time I saw him. And he had had a 10-year history of migraine. And it was incredibly bothersome to the point where he'd had to give up work altogether. And, you know, he'd not worked for several years now. And you can imagine all the financial problems that go with that, the marital strain that he was now under as his wife was angry and resented the fact that he wasn't working, and he felt a bit ashamed of it. And she, I mean, reading between the lines, I'm not sure she entirely supported the fact that this really merited him missing work. And so it was a whole sort of drama, this story. And he told me what he'd done to try and resolve it. If you go on to the next slide. He said he'd been investigated with MRIs, and he'd had lots of blood tests and a lumbar puncture. He'd had lots of complicated medication regimes and even this machine that was stuck on his skin. That's a whole other story, this machine. But anyway, he'd had it all, and nothing had really helped with his pain. So here he was, 10 years later, and he was upset with the treatment he received, and I couldn't quite get why. I said, look, you've had more investigations, more money spent on you than most people in the past 10 years looking for a cause, professionally worked up. But then if you come to the next slide, we'll get into really why he was there. He told me this really quite tragic story that he'd looked after his mother in her final illness. And he was quite a meek sort of bloke that looked like he didn't want to upset or offend anyone. And he, on the one hand, he wanted to be there for his mother. On the other hand, he didn't want to upset his wife. But he did eventually look after his mother. And his wife wasn't entirely pleased with that. But worse still, a brother thought that his only reason for looking after his mother was to try and just gain all their inheritance, which he was really, it just wasn't him, and it wasn't what he was trying to do. But when his mother died and the will was read, he was left nothing. And he just couldn't understand it, and he couldn't get over this, and he kept going back to it in his mind. We'll go on to the next slide. He told me that he had dreams in which he shouted at his brother. All the things that he was too timid to say in real life, he would be saying in his dreams. I'm no Freudian, by the way, but even I couldn't fail to miss the symbolism of what was happening here. He just couldn't express all this anger and hurt. He said he was edgy and tense. His brother, he said, was dead to me now. And interestingly, he said that the day his headaches first began was when he woke up and had been grinding his teeth at night. And this had produced a pain sort of somewhere in his temples. And he was sure that that's what triggered the headache. In other words, his view all along was that this was psychological. And he'd just not really been able to say that, and no one had really asked. And if you go on to the next slide, it reminded me of a quote from Henry Maudsley here of the hospital that I work at. It's named after him. "The sorrow that has no vent in tears may make other organs weep." Isn't that a lovely quote? And here he was, you know, this sorrow was at the heart of it. If we go on to the next slide. He said to me at the end of this consultation, he sort of balled his hands up as though he was screwing up an imaginary piece of paper. And he said, 10 years of my life, and he sort of aimed it at the bin which was in the corner of my room. And it was such a powerful image. This was a man for more or less a quarter of his life and perhaps a half of his adult life, just discarded. He'd had this headache that had ruined his life, and this visual image, every time I glanced at the bin in the corner of my room for about the next 2 months, I would feel this wave of sadness. So, okay, we'll move on. Santhouse's third rule. It's going to need some explanation. I've forgotten what it is, so you might need to move on the next slide. Having symptoms can be normal. So one symptom, this is just to show you the paper that I'm talking from, but it was about muscle fasciculations, which is where your muscles start twitching. You've all had that, I presume. I heard once, but I've not been able to find the paper, that's the #1 symptom that medical students worry about. Because every time a medical, you know, if you get a fasciculation in the corner of your eye, you think, I've not slept well, and a medical student thinks multiple sclerosis. There was a book called The House of God, and there was a wonderful quote from there that he said, when you hear hoofbeats outside your window, you think horse, and a medical student always thinks zebra. And so, anyway, if you go on to the next slide, what they showed is that persons reporting these fasciculations, these benign fasciculations, were in good health. And in fact, a lot of people stressed their own conviction that tension and fatigue were associated with the episodes. And this was an old study, and they said that benign fasciculations are widespread. In the absence of any other complaints or neurological signs, they shouldn't be the basis for alarm. But they commonly are, and they commonly send people to their doctors. We'll go on to the next slide. This is an old study that looks at fatigue in the population. There's a reference down at the bottom for those with eagle eyes. But basically it shows that the fatigue scores in a population are pretty normally distributed. In other words, fatigue is a common symptom for people to complain of. Obviously you have people at the extremes who have very significant fatigue, but some level of fatigue, some symptoms are quite common. If we go on to the next slide. So this was a more recent study from New Zealand that asked the question, how common are symptoms? And it asked them about the past week, how often they'd experienced symptoms. And if you go on to the next slide, so I'll just walk you through that. I might disappear off the camera, if that's all right. Just to show you. So this is the number of symptoms here. So the most symptoms people reported in the last week was about 36 or 7. That's a lot of symptoms for someone to have in 1 week. And this is the percentage of respondents. And what you can see is that the most common number of symptoms for people to have had in the last week was 5. So if you ask an otherwise normal, healthy population, how many symptoms have you had in the past week? About 5 is the median number. And there's quite a number of people who have had more than that. And lots of people who've had just sort of 2 or 3. And this might be dizziness or a bit of back pain or some blocked nose or stuffy nose or running nose. But having symptoms is the stuff of life. It's normal and it's common. And and I just want to get that in your mind, and we'll move on. Oh, that's your cue. I need a visual, like a hand signal. Which leads me to Santhouse's 4th rule, that symptoms are usually medically unexplained. And again, that's something that that's quite a striking thing. Very often we have a notion that if you go to the doctors with a symptom, you should come out with an explanation of why you've got that symptom. But let's have a little look at some of the evidence. So this was some colleagues of mine at King's College Hospital in London who looked at people. These are people who have made it through their doctors. They've been to their doctors, they've got a symptom, They've been sent to hospital now. In other words, they've made it through primary care, right? How hard is it to get a referral to a specialist? It's not easy. At least I wouldn't imagine it is. Impossible is being offered from the floor. And that's not an uncommon experience. But let's have a look at what they found. So this, the table was so busy that I've adapted the actual table that they used. And what it shows is that the percentage of cases of medically unexplained symptoms. So if you go to the dental specialist, you will find 37% are medically unexplained. Because of the way that studies are conducted, they say that it should fall between 25 and 48, but I'll leave out the brackets now. 41% of people going to a chest clinic, and you can see that if you're going to a gastroenterology clinic, it's close to 60% of people now will be sent away with symptoms, at least some of which are medically unexplained. And gynecology was the highest number, with neurology in second, so a full 2/3 of patients going to a gynecology clinic didn't have a physiological diagnosis, if you like, for their symptoms when they were sent away. So, I can guess what these were called in the notes. You'd probably, in dental, you might have got temporomandibular joint pain, and in chest it would have been some sort of atypical chest pain, and rheumatology, who knows, cardiology is non-cardiac chest pain, and gastroenterology, again, people with iffy bowels is a very common thing to happen. Neurology, unexplained seizures, pain, movement problems. Gynecology with pelvic pain that remains unexplained. In other words, every day throughout the hospital, this is happening, and it's really common. We'll just move on. The authors in this study said medically unexplained symptoms are common across general or internal medicine, that means the same thing, and represent the most common diagnosis in some specialties. Medical behaviour training and management need to take this into account. Well, I teach medical students, and they normally look like you do when I tell them about this, a bit sort of bewildered and slightly disbelieving. And, it's not really taught, I don't think, at all. But these studies are replicated, and I've given you one study out of several that says the same thing. If we move on to the next slide. So this was in the USA in primary care. So this looked at common symptoms like dizziness, chest pain, I think back pain, but symptoms that you might commonly see if you're a GP. And I'll just take you to the next slide. And I just want to draw your attention to the bit underlined in red, which was an organic etiology was demonstrated in only 16%. So if you go to your doctor, certainly at that stage in the United States, this was in the late 1980s, in the studies referenced at the top, and it shows you that although they did diagnostic testing in more than 2/3, they only found something actually wrong to treat in 16%. And as I recall, treating it only made a difference to about half those patients. So it's really common both in primary and secondary care. I don't want to labour the point, we should probably move on. So, fifth rule is that unexplained symptoms are often associated with depression and anxiety. Not always, of course, and there's lots of complicated reasons why people present with symptoms that remain unexplained, but depression and anxiety can be one of those reasons, which is why it sometimes attracts the attention of a psychiatrist, although, again, there's lots of other reasons. So let's move on. So this is that study I showed you before about fatigue from the early 1990s. And what this shows is that I'm going to again move over here. This shows how fatigued you are. And this is what's called the General Health Questionnaire, which is a measure of psychological distress. And what you can see is that as the psychological distress increases, so the fatigue score seemed to increase. So we'll just move on again. This was a study done across 5 continents in lots of different centres that looked at over 25,000 patients. And what they showed was that half the depressed patients reported multiple unexplained physical symptoms. In other words, it seemed to be a reflection of their depression. It's quite common for depressed people to either experience symptoms, or if they experience them, for them to be more bothered by them, but certainly it's a more common thing to have. So if we just move on to the next slide. What was interesting, I thought, out of this study is that, I mean, there was a range, and I think it must have depended on what centre you were seen at or where you were, but it was very common for people who are depressed to report only physical symptoms at first. And my own experience is that men probably do that a bit more than women. Their sort of entry into the GP surgery is to complain of something physical rather than emotional or psychological, and I think that explains perhaps why, to some extent. So that's the sort of psychological aspect with respect to depression, anxiety, mood, and that sort of thing. Let's move on to the next slide. I call this first, doctors can make it worse than usually do. I think that was unfair. I don't think doctors usually do. I think doctors, in particularly, well, everywhere, but particularly in primary care, do an incredible job under really difficult circumstances, often seeing people very early in the course of the illness where they need to make judgments about what symptoms mean. But I think there is a way in which doctors can make things worse. And if we just move on. I think the problem can be this focus on disease. When I told you before about how we construct medicine these days, with this focus on disease and looking for the pathology as an explanation for why someone is sitting in your surgery. So doctors tend to over-investigate very often. You know, you go in with a symptom and the doctor says, and sometimes it's fair enough, of course. I mean, I don't think a doctor can just dismiss symptoms. It can be a difficult judgment to make. Often then you get very simplistic explanation based on disease or damage models. And by the way, this slide I'm very indebted to Simon Wesley, who's a colleague of mine, just to give him due credit. People get round to introducing psychological explanations when it's too late. So what you do is you investigate the patient, you then give them fairly simplistic explanations based on a bit of the body having gone wrong. When you can't find it in the end, you then say to the patient, I wonder if this is psychological, at which point the patient is often pretty offended or annoyed by that. You know, or you've spent 6 months investigating me, and suddenly now you're telling me it's in my head, are you? Or words to that effect. And people are understandably put out by that notion. So the doctor will then often, as a sort of peace offering, so to speak, agree to investigate them even more. And so the cycle can go on. And I think that is a problem. Okay, let's move on. I think the seventh rule is that we just can't afford to do this anymore. This way of practicing medicine is not only, I think, bad medicine, but it's also unaffordable. And I'm just going to show you in the next slide. This is from the King's Fund report. And what it says is that people experiencing MUS, which is medically unexplained symptoms, are typically referred for multiple investigations and assessments at considerable expense to the system and with little or no benefit for the patient. Certainly that's been my experience. The NHS in England is estimated to spend, they conclude, this is from a study that they reference, at least £3 billion each year, and this is in 2010 by the way, £3 billion each year attempting to diagnose and treat medically unexplained symptoms. Much of this expenditure currently delivers limited value to patients. At worst, it can be counterproductive or even harmful. So if you want to save a few billion, the government should just ask me, and we'd resolve a lot of our problems. So I think that's the next point, is that it's expensive and it's often unnecessary. It's bad medicine. Let's move on. This is a I'm not sure how subtle this point is. It's something that came to me from reading a paper by Greco and Sharp a number of years ago. And if we just move on to the next slide. Before I try to explain to you what the difference was between disease and illness, right? So disease is the pathological process that's going on in your body. So if you've got a bacteria and it's attacking certain cells in your body, and I open up your body, I will see what disease you've got. I'll see, oh look, it's eaten half their heart away, no wonder they're a bit breathless, or their liver's gone, or whatever it happens to be. Illness is what the patient is complaining about. A patient comes to you saying, I feel ill, I've got these symptoms, I'm a bit breathless, or I'm a bit dizzy, or something along those lines. Okay. So illness is what the patient experiences. If you have a patient with a clear-cut disease, and you take their blood and you can find this bacteria that's causing their disease, the patient is entirely blameless, aren't they? You say, oh, you poor thing, you know, take a week off work, here's some antibiotics, you've got 3 generations of your family by your bedside giving you all that love and care and attention that you've been craving for the last few years, and everything's fine. But what if you have symptoms, but you don't have a disease? The doctors say, look, we've investigated you, and I know you feel unwell, but we can't find any disease at all to treat. Now what do? You go back home and your nearest and dearest says, how was the doctors today? And you, okay, well, what was the diagnosis? There wasn't one. Right, so back to work, great. But the person might still feel ill. And that's a problem, isn't it? Because if we go on to the next slide, illness without disease is often seen as suspect. Patients are seen as perhaps exaggerating symptoms, or it's not quite real. By the way, I don't believe for a second that that's the case. I think people develop symptoms for subtle, complex reasons, a complicated interaction between the mind and body that maybe we can talk about later, but you don't always find the disease, you don't always find the pathology. But because we have a strong need to, because doctors fulfill the role of legitimizing the patient's illness. If you've got illness without disease, then it's somehow seen as a kind of a moral failing almost. And I think there is a cultural reason why we keep getting into this situation all of the time. So let's move on. Patients and doctors therefore generally like having a diagnosis, don't they? At first, the first version of this slide said doctors because they feel clever, and it's true, I do feel clever making a diagnosis, but that's again a little bit unfair. I think it allows doctors, if you like, to tie off a problem. You encapsulate it. When you've got a diagnosis, it's quite crisp. You can estimate what someone's prognosis is. You can say, and the trials on this diagnosis show that this treatment is best, and this is your outcome. So a diagnosis is really quite containing. But illness without a diagnosis is a problem, and therefore patients also want a diagnosis. They want very often to be able to understand and make sense of their suffering. Okay, let's move on. I think my next rule is that we often think that if we investigate patients, let's say you go to the doctor with a symptom. Let's say, I don't know, you've got a cough and you don't like it, and you go to the doctor, and the doctor's thinking, well, maybe I'll just do a chest X-ray just to be safe. What very often happens is that a little undetermined blob will appear in the chest X-ray, and what was a simple problem of a cough before now becomes a great big medical drama. You know, what is this blob? You go for a CT, they're not sure, an MRI, should you biopsy it? If you biopsy it, will it start bleeding? And will you have another problem after that? In other words, over-investigation is not benign at all, and yet somehow over-investigation is tolerated. Under-investigation, if you miss a diagnosis as a doctor, because you've not really investigated the patient, you won't easily be forgiven for that, I don't think. Whereas if you over-investigate it and cause a little bit of damage, people say, oh, you know, he's a bit cautious, maybe he didn't have to do it, but I could see why he did. So over-investigation is sort of encouraged in our current medical system. And again, I'm not blaming individuals. I understand why it happens. I'm saying as a culture, as a society, we've somehow brought it to this point. And you seem like exactly the sort of audience to bring it back. You're an ethical society, right? You can... But anyway, let's move on. I mean, I might be over-egging it with this next slide, but I just wanted to show you a normal distribution slide. You've probably seen those. Blood tests, when you have a blood test, it's based on a normal distribution. So it says what percentage of the normal population will fall between these two parameters. The problem is that outside, at the extremes, you get people who are ill, but you also get normal people. So the more blood tests you do, you will often end up taking normal people and showing an abnormal test result. And again, that can prove to be a problem for patients. So when the doctor sends off 100 blood tests, they never do quite 100, although some try, but 20 blood tests, you might expect one of them to be normal or on the boundaries of normal. And that can cause a problem as well. Okay, we'll move on to the next slide. A problem that a lot of patients tell me is that they just have investigation after investigation. And I remember seeing a patient who had been, poor bloke, sent from pillar to post. He had dizziness as I think his primary symptom, and one of hundreds of examples like this, by the way. And the thing that he said, which a lot of people say, is they go to a specialist, they have a ECG, tilt table tests, prodded, poked, scanned, and the doctor will sort of come in trilling into the surgery, good news, nothing wrong with you. And the patient thinks, oh no, you know, there is something wrong with me, just what is it? And they get sent on and on to the next person. The person I'm thinking of had seen, I think it was 6 or 7 specialists by the time he came to see me. And I was pretty clear in my own mind that this was nothing more and nothing less than an anxiety disorder. And over-breathing makes you dizzy. You can try it now. In fact, don't. I'm not rescuing any of you. But if you breathe in and out quickly 10 times, you'll feel dizzy too, because he was anxious and panicky. And I suspect the doctors knew that. You know, I've never met a badly intentioned doctor, and I've never met a doctor that didn't always try their best for the patient, but I think somehow the system that we've got caught up in just encourages this type of patient interaction. So we'll move on to the next slide. So my almost final rule is that psychiatry is medicine. I think for a long time we've had this very dualistic view that you've got your physical health and your mental health. And you know, it's interesting that I'm one of a very small number of people that work in a physical health, a general hospital. But mostly psychiatry is separate from the medical wards. So it could be it usually is in a different building and often on a different site altogether. And it just encourages that way of thinking. So I'm trying to discourage that and to try and introduce the idea that psychiatry is at the very heart of medicine. Because if you go to the next slide, you know, in the book I talk about all the ways in which psychiatry comes into the general hospital. I mean, one of the things that I did when I started at Guy's was why people want to give their organs away, not to a family member, but just to whoever wants an organ, whoever the hospital thinks could make best use of it. And it became a very interesting area. There's a discussion, a chapter on that about what I found and why people want to refuse life-saving treatment. Why do some people want the end to come sooner? All of these things troubled me. And if you don't have a psychiatrist sort of embedded within a hospital, these things can just slip by. I mean, I started at the beginning talking about seeing patients who have self-induced illness, but the estimates are that 1% of all hospital inpatients have a self-induced illness, which is an extraordinary number. People who inject themselves with insulin or or who do all sorts of things to join the healthcare system. And again, it's easy to miss, particularly if you're not aware of it, you don't know the diagnosis, don't have time to think about it. Chronic pain, again, is an area where the psychological and the physical are very intertwined. As any of you know, when I did casualty for 6 months as a very junior doctor, and back then they just let you get on with it. Goodness knows how, but they did then. And I often used to wonder why I saw people with toothache at night. I never learned about teeth at medical student. We sort of stopped at the jaw and missed the teeth out and went up to the brain. And I began to realise that people at night came in with toothache because they had nothing else to think about apart from how much their jaw was throbbing. And during the daytime they were distracted and they had things to do. But it led me to understand that the experience of pain, patient behaviours, weren't directly related to the symptom they had, but how they felt about it, whether they were distracted from it, their mood, emotion, etc. And of course, COVID-19 and how that's changed the world. That's a whole other story. But I think I'll just go on to my 12th rule, which is I'm always available for questions, weddings, bar mitzvahs, or or anything else. I'm your man. I think that's probably enough for now. I said I finished between 2:45 and 4 o'clock, so thank you.